Hello, and welcome to the latest episode of our Heart Connection 2022 virtual webinar series. This month, we are talking about transition and lifelong care. My name is Becca Kalivas. I am the Education Director for Conquering CHD. I will be your host and moderator for today's webinar. What is transition and why does it matter? On today's episode, we welcome clinical experts as well as parent and patient panelists. Dr. Katie Salsiccioli is an adult congenital and pediatric cardiologist at Texas Children's Hospital and an assistant professor of internal medicine and pediatrics at Baylor College of Medicine. She completed internal medicine, pediatrics, and pediatric cardiology training at Baylor College of Medicine and advanced training in adult congenital heart disease at the University of Michigan. She loves helping patients understand their hearts and engage in their care in order to confidently pursue their goals, especially as they transition from pediatric to adult care. She is passionate about teaching patients and families, as well as future medical professionals, to continue to advance the field of adult congenital cardiology. Dr. Mary Jenkins is an internal medicine pediatrics PGY4 and chief resident at Tulane in New Orleans, Louisiana. In her life prior to medicine, she was a high school teacher in Washington, D.C., and first discovered a passion for the education of adolescents as they emerge into greater independence. She is currently applying for a pediatric cardiology fellowship and plans to pursue a career in adult congenital cardiology. She also serves on the Conquering CHD Transition and Lifelong Care Committee. Meredith Atkinson is a mom to 17-year-old twins, Mirabelle and Sophia Atkinson, one born with multiple critical complex congenital heart defects. Meredith lives in Washington, D.C., and worked for a decade on Capitol Hill. She and her daughters have served as advocates for individuals and families of those with congenital heart disease since they were born. They have participated with various local and national groups in promoting awareness and seeking funding for research and improved care for congenital heart disease patients. Meredith also serves on Conquering CHD's Transition and Lifelong Care Committee. Jennifer Weiner is the content coordinator and lead ACHD coordinator for the Conquering CHD and is an adult with CHD, born with truncus arteriosus in the early 1980s. She has had 3 open heart surgeries in ICD and is currently being seen in the Chicagoland area by the Advocate Adult Congenital Heart Team. Growing up, ACHD care was not available. As a result, Jennifer did not transition to adult care until she was 30 years old. Welcome, panelists, and thanks for joining us. Before I turn things over to our panelists, there's a few housekeeping notes. Following a brief presentation, our panel will be answering questions you submit using the Q&A feature at the bottom of your screen, as well as those we've received via social media. If we don't get to your question live during the webinar or you have follow-up questions, please email us at info@conqueringchd.org. Our panelists will not address questions specific to your medical diagnoses, but will speak in generalities and provide relevant resources for families to learn more. As always, with information learned, we encourage patients and families to discuss their specific concerns directly with their care team. With that, I will let Dr. Salsiccioli start us off by explaining a few key points related to transition.
Hi, everyone. Thanks for taking the time to join us this evening to talk about a topic that is near and dear to my heart and so important for all patients and families with congenital heart disease as their children grow into adults. So we'll go very briefly over kind of the definition of transition and why it matters before we get to questions and a discussion with the full panel. Becca, thanks. So one key difference is transition versus transfer that I'd like to talk about the definition. So a lot of people think that transition is transitioning from pediatric to adult care, but really transition is a longitudinal education and preparation to ensure a successful transfer, which is the actual changing from pediatric to adult care. So this education encompasses everything from what is my diagnosis, what surgeries have I had, to how do I create a living will, how do I schedule a follow-up visit, what's the deal with insurance, how do I pick up prescriptions, all sorts of topics about how to adult with relation to their heart disease and their healthcare. Transfer is the official line in the sand where you move from a pediatric cardiologist to an adult congenital cardiologist. That time when you say goodbye to the person who you have grown up with, who has gotten you through good days and bad days, and meet a new physician or healthcare provider who will be taking over your care. Next slide, please. So this slide comes from a recent paper from the European Heart Journal talking about the components of successful transition and a proposed timing for implementation. The big key with this slide, and that I'll talk about throughout, is that the transition process should start earlier than it seems. Some people would argue that the transition process should start during fetal counseling after a new congenital heart diagnosis is made before birth, to introduce the idea that we expect these children to grow up, to become adolescents, to become young adults, and to learn how to live with their heart disease. So being introduced to the idea of taking over their own healthcare can be introduced as young as 12, but definitely by age 14, as you can see on the bottom lines of the chart here. Working with the transition education team, counseling and education over the many different areas that I mentioned on the first slide, addressing their adolescent healthcare needs, the sex, drugs, and rock and roll of the teenage and young adult years needs to be addressed, as uncomfortable as it may seem, as well as talking to the parents and encouraging our children and young adults to gradually take ownership of their care while holding their parents' hands as they gradually kind of back up and allow their children to be the independent people that we're hoping to grow them into. Sometime before the age of 18, ideally the pediatric cardiology team will identify an adult congenital team, specifically, hopefully a specific physician or team to transfer them to, and facilitate contact both with that team as well as other peers who are going through the same transition process. At Texas Children's, we do peer nights and have a lot of our transition age young adults meet each other, chat about challenges, struggles, successes, and just kind of talk with people who understand what they're going through. And then sometime around the age of 18 to 20, there's no specific official line in the sand for when that has to happen. The official transfer to adult care would happen. And so transferring from pediatric cardiology to adult congenital cardiology care. Next slide, please. So I tend to like these type of diagrams a little bit better, but the key thing I want to point out with you here is that the patient is really the team captain. And so all of the education efforts, all of the things that the different members of the team are doing really center around the patient. Some people pick up information really fast. They know their diagnosis. They're totally cool with everything. Some people want nothing to do with it. And it has to be a much more gradual graded process. Surrounding and supporting the patient are their physician, nurses, and educators on the team, often social workers who are talking about how insurance will change when they become an adult, what a living will is, what an advanced directive, all of the paperwork aspects of being an adult that no one tells you about when you're a child. And then the parents and other family who are the support. Early on, they're really the co-captain, and then they become more of an assistant coach, kind of backing up and giving the patient more independence as they grow older. The diagram at the bottom is very similar to what we looked at on the back page, with a little bit different of a flow chart. Instead of thinking of things happening sort of multiple things at the same time, this is a little bit more of a flow sheet with what happens younger towards what happens older. But the big key is that it starts early, it's iterative, and it's driven by patients. Next slide, please. So we are very fortunate that more than 90% of children born with congenital heart disease survive into adulthood thanks to advances in cardiology and cardiac surgery care. Unfortunately, though, based on a recent study in the European Heart Journal, more than a quarter of patients experience interruptions in care. And as you can see on the figure on the right, which is an older survey study based in the United States from 2013, suggesting that many more people actually have gaps in care of at least 3 years. About a quarter of patients with severe complexity congenital heart disease, and more than half of those with mild congenital heart disease. It's such a hard thing to track because if people are not in care and don't come back into care, it's really tough to know what that number is. But no matter what range these numbers are actually in, it's much too high. And I'll talk a little bit about how transition education can address this gap and what we've seen with our program at Texas Children's, with how transition education keeps people in care, because we know that keeping them in care is really important in preventing adverse outcomes. Next slide, please. So what are some of the reasons for poor transition? The big things often come down to social determinants of health. So what is the environment? Many people don't live close to care. It's hard for them to navigate the medical system. And many times pediatric cardiologists have never had access to adult congenital care and are unfamiliar with who to transfer someone to. Somebody may hold on to their patients. Patients may age out and just not be seen. From a healthcare perspective, there's not enough ACHD physicians around. There simply aren't. There's lots of great resources for finding the closest ACHD physician, but there's lots of deserts and gaps around different areas of the country where ACHD care is hard to find. So finding a pediatric cardiologist or an adult cardiologist with some interest in ACHD may be the best option, at least in the short term. From an economic stability perspective, becoming a young adult with CHD can be challenging. There are numerous studies looking at attention deficit challenges, challenges with employment, other sort of frontal lobe issues that mean that as a whole, the population is a bit less likely to be employed. They're also more likely to require time off for medical care, which may make steady employment and the resulting health insurance that's often tied to jobs a more challenging situation, putting high costs on patients to achieve their routine medical care. And then education. So this is where it comes down, in addition to sort of overall education, health literacy and transition education. So understanding how to navigate the healthcare system independent of the transition education and understanding their own disease. All of these kind of interacting together, as well as the lapses and then kind of structural issues, are big contributors to poor transition and increased being lost to follow-up. Next slide, please. So this is a survey study again from the United States back in 2013, looking at the reasons that people had gaps in care. And for patients who felt well, patients who had moderate complexity disease, patients who had severe complexity disease, not knowing they needed to follow up was a very common reason. They also cited reasons like not receiving any medical care, losing insurance, feeling well, moving, lots of things that may make it so, oh, a couple months without seeing my doctor, oh, a couple years without seeing my doctor. But improving transition care can address these gaps. Next slide, please. These gaps lead to poor outcomes. So this was a study from about 15 years ago or so that looked at factors that were associated with needing an urgent intervention in adult congenital heart patients. And having a lapse in medical care of greater than 2 years had an odds ratio of 3. Patients were 3 times more likely to need an urgent intervention, which was almost as great of an increase in likelihood as patients who had symptoms. So it's really, really important that patients don't have these fallouts of care, because when they come back in, they're more likely to need something urgent that potentially could have been done in a more organized, less urgent manner. Next slide, please. Our program at Texas Children's with Dr. Kayla Lopez has been really transformational in how we've been able to change our transition program and keep patients in care. This data is unpublished, but being worked on, has been presented in abstract form. But looking at before our transition education program was implemented in 2016, only about 27.8% of transition age patients were still in care at the end of that 4-year period, compared to after initiation of the program, where 86.2% of patients were still in care. So transition education matters because it improves the not knowing they need to follow up, but it also teaches patients and their families how to address so many of those other barriers that we identified in navigating the transfer from pediatric to adult congenital care. Next slide. So I hope that I have convinced you that transition matters. I hope that you understand what it means. It's an education process over a long period of time to enable patients to manage their healthcare, to understand their diagnosis and how they can take ownership over it moving forward. And I look forward to the conversation that we're going to have as a panel moving forward.
Thank you, Dr. Salsiccioli, for that important background information. At this point in the webinar, we will open it up to questions from the audience. As a reminder, please submit your questions through the Zoom chat or using the Zoom Q&A feature at the bottom of your screen. And I will ask all of our panelists to turn on your cameras and unmute. So one of the things that we get questions about a lot from both patients and families is there's a massive difference, I think, between pediatric CHD care, adult CHD care, and general adult heart care. How would you briefly explain those differences between pediatric and adult CHD care?
So I think probably the biggest difference is between pediatric and adult CHD care versus general adult cardiology care. So transitioning and transferring between pediatric cardiology and adult congenital cardiology hopefully is a pretty smooth process. So adult congenital cardiologists understand the physiology, understand the surgical history, and ideally will understand what patients and their families have gone through prior to arriving. They're familiar with guidelines for caring for patients with adult congenital heart disease. The ACC guidelines for the United States were just released, the updated version in 2018. And are familiar with those guidelines and how to care for patients. They understand the challenges of the transition and transfer process and are ready to meet these patients kind of as they come from pediatric cardiology, knowing that it's probably a pretty emotional thing for some of these patients who've been cared for their entire life by their pediatric cardiologists. And ideally working with two-way communication to feed back how things are going to their pediatric cardiologist after receiving information about the transition process ahead of time. General adult cardiology care is wonderful, and in some places it's the best option for patients who may not have easy access to pediatric or adult congenital care. But adult cardiologists actually are required to have very little adult congenital training. 6 hours of lectures is their current training requirement, was even there for previous generations of adult cardiologists. And so one thing that the adult general cardiology community is really working on is networking with these physicians who are in places far away from ACHD docs to co-manage patients, to make sure they understand the guidelines, to know when they need to come to an ACHD center versus being managed locally, to try to ease the burden on families, to empower the local adult cardiologists to manage kind of the easier, more straightforward issues, but know when that really expert tertiary level care is needed.
Thank you for that answer. I think we all know CHD care varies across the country. Is the transition process from pediatric to adult care the same at different institutions? Do all programs have a formal transition program? How would I know as a parent whether my center has that type of program in place?
I would say you're going to see quite a variety in how different places are going to approach transition. And that is not just limited to the cardiac world. You're also going to see that with your general pediatrician and how they approach transition as well, because that should be occurring with the pediatrician as well. So some centers are going to have like a very structured approach. Some will involve social workers kind of leading the charge, where they'll have separate meetings sort of set up focusing on transition. Some will have the physician lead it, and they'll do transition readiness assessment questionnaires to go through and do some coaching during visits. So there is quite a bit of variety. And I think that like one of the most important things is to ask wherever you are, what is the approach to transition here? And some places don't have an approach yet. And that's really a good opportunity to raise that as a concern, especially on the earlier end. It's never too early to ask. So if like you have kids that are even like 10, 11, 12, asking what the transition sort of policy or strategy is at your center. And if there isn't one, then that's a really great opportunity to ask what their plans are for implementing one.
Can I just jump in quick with a comment about that? My daughter is 17 right now, but she had a need to change cardiologists when she was about 11. And I thought, we'd already been talking a little bit about transition, and I thought, I don't want her to change to a new cardiologist for 2 or 3 years or 4 years and then change again. So we approached the adult program and asked if they would accept her, and they said yes. And so, of course, she was the youngest patient, and she may still be one of their younger patients, if not the youngest. But it was the right time for us. And so I think, you have to kind of look and see what your situation is and know your child and know what might be good and what the provider might be, and see when the timing's right. Because I think for us to change twice would have been a lot harder. But the transition was good. And once we changed, the approach seemed very different, I think, because from the pediatric cardiologist, we spent a lot of time talking about the structure of her heart and how things were going. But all of a sudden, when she was in the adult practice, they talked about quality of life a lot more. And that was really important at that time of her life too.
On a similar note, I wanted to add to Meredith's response. We had zero transition when I was coming of age. So it was kind of left on my parents to tell me everything that was going on with my condition. I didn't know I had to see a doctor every year. So when I finally did make that switch, it was very abrupt and very kind of, I was taken aback by it and felt that and I was an adult at that point, I was 30. So it kind of made me feel a little bit betrayed by my pediatric cardiologist, that I wasn't aware of things that would go on as I became an adult. and wasn't aware on, the different approach that adult doctors take to you as a patient as opposed to pediatric doctors. It's very different, and it can be quite jarring when you're suddenly in an emergency situation in the hospital and being treated like an adult when you're used to being, I guess, a little more coddled, I guess is the word.
Yeah, I would agree with that 100%. I think, like Meredith said, the age people actually transfer at is really variable. So we have new patients into our system. If they're older than 16, they automatically get set up with an adult congenital doctor. So they're not meeting someone and then transferring, a year or two later. And I think talking about starting the conversation earlier, especially if you're at a place that has people with multiple training backgrounds. So I see children and adults. And so I would love to get teenagers and keep them for the rest of their life and work on the transition process, even though they won't have to transfer, because I can care for them for their entire life. So I think that's a great highlight of the role of transition education. I think that the ACHD doctors are much more comfortable talking about the tough stuff. So can I have kids? Do I need to be on birth control? What are the chances I'm going to pass this on to my children? What happens if I do cocaine? Things that make some of the pediatric doctors squirm a little bit, that it's important to ask about and to know about ahead of time, so you're able to at least have an idea of what those consequences might be instead of finding out on the back end how things turn out. So I think that's one area that people with adult training may have a little more comfort with, normalizing those types of conversations instead of feeling uncomfortable.
I think that's a great point. Thank you. Kind of piggybacking on that discussion a little bit. CHD care, as we're seeing, can be really complicated, even for some of the more straightforward defects. Is there a roadmap of sorts that can help explain to patients and their parents and families what kind of care they might need or should receive at various stages?
Sorry, I feel like I'm talking a lot, so I'm trying to slow down and let everyone else participate. I think, the first time I meet people, I try to set sort of short-term and long-term goals and short-term and long-term expectations, but I always open with, what have you been told before? What have you been told to expect 1 year from now, 5 years from now, 10 years from now? Sometimes people have been told, yep, I'm going to need another operation. It's a matter of time. Sometimes people have been told, I was told I was going to need an operation 5 years ago, and I'm still kind of chugging along, doing okay. Sometimes people have been told you could never have children when in fact they're pretty low risk. And so I think establishing what understanding and expectations are, and then working on laying a framework for expected studies, expected interventions, expected symptoms, and as much of a time frame as you can lay out for those things is really, really helpful for a first visit and kind of making a plan. And then, like was discussed before, a lot of adult cardiac congenital care is symptom driven and quality of life driven and goal driven. And so making sure you understand what a patient's big goals and sort of deal breakers are in establishing that plan is really important. That only sort of answered the question.
I think Dr. Salsa also really alludes to the idea of meeting patients where they are. And so I feel like being med peds, I see adults and I see kids, and I sometimes see 14-year-olds that have emotional maturity of maybe a 25-year-old and a 25-year-old who has the emotional maturity of a 14-year-old. And so I think we see these different maps, which I think, are meant to be a guide of how to approach transition, but it shouldn't certainly induce panic if someone is to look online and say, oh my gosh, we haven't been doing this and they're already 16 and all hope is lost. It's really about just meeting people, I think, where they are. And we're going to have, and certainly, as we're alluding to, sometimes if there's learning disabilities or sometimes patients with Down syndrome, which is also quite frequent, within your patient population, we see that transition is going to mean different things and has to be individualized as well. So I think also it can be an empowering thing, particularly if you're in a position where you're at a center that's not outlining this for you, is to be able to find those resources and look that up, but then not to be discouraged if you're not following it exactly the way it's written out. It's more important to go slow and be comfortable than it is to rush through something and not really have a full understanding of what's going on.
So if I can add something,
Yeah.
my daughter doesn't seem to have a very specific plan some of the time because she's very complex. And I think that you're going to find that, and speaking as a non-doctor, I think you're going to find that the plans are going to be very different from someone who's simple or complex. And even when we've seen different physicians come and work at the hospital, the plans change a little bit because the new doctor will have a new idea about the transition plan. And so I feel like, and that's kind of been a stumbling block for my daughter because she's like, well, what am I supposed to do? I don't know if in a year I need this or that. And so it's a challenge when there's all this unknown, when my daughter is like starting to plan to go to college and trying to figure out where she wants to go. And she needs like solid answers in her mind. And yet there are no solid answers. And so I think it's nice that we at least can say, okay, our kind of plan is you're going to see a doctor twice a year. You're going to see your regular cardiologist, and you're going to see your electrophysiologist. But in between, she has never had a year, I think, since she was probably 10 or 11, where she hasn't had things come up where she's needed extra intervention throughout. And so it also throws off the plan. And so I think I don't know how to really navigate it, because I think for us, we're trying to have a plan that gives her solid information, but everything is constantly in flux. And so there's a give and take, and she's just got to get used to that, I think, which is hard.
I completely agree. One thing that I like to do that I have found has been pretty helpful is to tell people what I know, what I think, and what I don't know. And so when I'm saying, kind of laying a plan or an expectation, I'll say, I know that we should do this. 10 out of 10 cardiologists would say this is the right thing to do. And for some of the gray zones, I will be very upfront with saying, I'm not sure what the best option is in this situation. I have no ego about calling a friend. We have a lot of multidisciplinary discussions about sort of what we should do in situations in gray zones. And I think being upfront and honest about the unknown and the gray zones, as frustrating as it can be, can also alleviate some of that sort of discomfort with the unknown to some extent, to know that none of us are super comfortable with what's going on, instead of having multiple people come in and say A is right versus B is right, and changing the plan, like you said, saying, I think these are our options, let's see where things go, and then letting kind of a patient's goals and deal breakers, like I said, help drive that decision making. But it's so hard. It's so hard not knowing. And I feel like the more we learn, the more questions we don't know the answers to in CHD, as we have whole generations of people growing up who are the first XYZ of their age or something like that. And it's really challenging. And I can't imagine how challenging it is from a patient perspective, because it's something that really pushes us and is emotionally tough to handle.
So I want to add that I think this, outside of the transfer of care, I think a big part of transition needs to be helping the patient feel comfortable with the provider and being able to ask the questions. I often just step out of the room and I'm like, okay, go for it. Talk about whatever you need. I'll be back in a few minutes, because I need her to ask the questions. This is her life. It's her body. She needs to ask the questions.
Even as an adult, that can be tricky, because I've, had to change doctors due to the doctors in my area leaving town and meeting the new person and not, jiving with them necessarily, and their personalities might not click with yours. So it can be quite intimidating to try to get a question in there when they're talking, and they feel they have the answers, but they don't quite know you yet to know that you're not comfortable. So it can be really tricky.
Yeah, and I think an important part of the transition process is empowering people to speak up and to ask those questions and to say, I don't feel comfortable with this plan, or even to recognize that they're not meshing with the person, because there's not a ton of adult congenital doctors around, but there's enough to ask for a second opinion, or to go see someone, or find someone local, a general cardiologist who will co-manage with a farther away adult congenital doctor if that's what you need. But being able to have someone that you trust, that you can ask those tough questions to, that you feel comfortable with, is absolutely critical in ensuring a successful transition, and being able to use all of that, or transfer, and being able to use all of that transition education that was obtained. If you don't feel comfortable, it's just going to sort of sit inside and not be able to be expressed.
I think we've alluded to a little bit that this is very much a dialogue between patient, family members, and your care team, which can be really hard to navigate as a parent and a patient. So I appreciate that information. Sometimes as a parent of my own child with CHD, having even just a list of what to ask makes a big difference because it takes that confidence piece out of it. It makes me feel more comfortable just knowing that I have, something with a list of questions to ask. So what kind of information should I know or have access to as I transition from pediatric to adult CHD care or prepare my kiddo for doing that? And are there any resources available to help me or my child navigate this process? Along similar lines, Jenny and Meredith, I'd love to hear your perspectives as parents and patients about the kinds of things maybe, Jenny, you wish you knew at the time, and Meredith, what you're helping prepare your daughter for now. Sorry, I threw a lot of questions all at you guys.
Yeah. Well, I can start with what I wish I knew. Like I said, there was no transition when I was becoming an adult, and I had no idea that I was going to have complications as I grew up. I didn't know I'd start having arrhythmias. I didn't know I'd need a pacemaker and then an ICD and all that stuff. So it was a big shock to me. I didn't know that I'd eventually switch from my pediatric doctor to an adult congenital. So it was a big adjustment because I wasn't prepared, and I wish that someone would have told me when I was, 10 or 11 years old that, like, as you grow up, these things will start to change. Because I was still from that school of thought where I was fixed. I had my surgeries. I was good to go. So it just came as quite a shock. I think that's my parents did a very good job of being upfront with me from the get-go, like what I had with the name of my defect and all the surgeries I had. But I wasn't prepared for the future, I guess. And I think that would be the one thing I would stress to parents and doctors to share.
Yeah, so in terms of what I'm trying to help my daughter with right now is one of the big questions we ask every appointment recently in the last maybe year or so is, what should I feel like right now? Because I think she has pain a lot of the time. She has chest pain. She feels pressure a lot of the time. When she climbs stairs, she has a hard time, things like that. And she sort of always thought that she wouldn't feel like this. And as she gets older, it becomes, and she's only 17, but as she's gotten older, it's increasing. And so she doesn't know what's normal. And so when we go in and she says, well, I feel this way, and they didn't say anything will fix it. And I say, well, maybe it won't be fixed, or why didn't you, or we'll come home from an appointment and she'll say, well, I didn't say it because the answer will be the same. And I say, no, you have to tell them every single time we go, I feel this, is this normal? And so that's the conversation we have every time is, you are going to feel some chest pain, but this chest pain is okay. And so they'll go through, she recently had a stress test. And so they said, when you are exercising at this beats per minute, it may feel hard, but it's still okay. And that's good. It's not a problem. And that's a really hard lesson for her to learn because she doesn't like feeling pain and she doesn't like feeling like she's less than. And so that's a tough one. But I think another thing that is in the forefront of her mind is, as she's looking at college, is she started looking, independent of any conversation I had with her, at colleges that are close to places where she can receive care. And I thought, as kids go to college, like, that age is so hard anyway, but to have that extra burden of like, well, I can't go somewhere where there's not a good doctor. That's just like an extra layer of everything you have to put on, aside from like, how do I deal with insurance? How do I call the pharmacy for my medicine? All of that. And so I think these are things to think about, and just be gentle and be supportive with these kids as they're transitioning. And they're still going to be transitioning. Even if my daughter moves away to school, she's going to be transitioning for probably a few more years as we figure things out and how she learns to do it on her own.
Yeah, adding to that too, Meredith, once she becomes a graduate of a college, it's going to be, what kind of job can I have that will offer insurance? And that becomes another thing that you have to consider as you're taking over your own care.
There was a study we did at TCH a few years ago, a survey study looking at teenagers before transition, asking them what they thought they needed to know for a successful transition and transfer, and then young adults who had transferred, who were asked, what did you wish you knew before you did this? What should we have included in the transition education? And there was so much mismatch between the two. The young adults are very concrete in the, how do I get a medication? How do I know where the pharmacy is? And the adults, much like Jenny kind of talked about, were like, what's next? How am I going to feel? What's normal? Like the bigger picture, zoomed out things. And so I think it's really important from the kind of healthcare side of things to kind of acknowledge the questions that are there, obviously, that the patient brings, but to also kind of gently introduce these other topics that may not be on their radar, and to sort of try to find a happy medium between your prerogative and what their questions are. So like you said, having empathy and kindness and figuring out what they want to learn at visits, but also making sure that you kind of address some of the bigger issues that they may not know how to ask, because they've always just been, what's my echo going to show the next year? Not what's my life going to be like now that I'm an adult for the next 20 years.
And it's nice that CCHD does offer those transition packets, which include questions. And I think that's a really huge, vital resource, because sometimes I think it's the things we don't know that are, oh, I wish I had known to ask that question. I think that's where it can be hard, is that of course we have blind spots, and like I feel like that frontal lobe is not developed in our lovely adolescent. So it's hard to really anticipate what they're going to need to know in adulthood. So that's a great resource to turn to for both parents, but also for young adolescent patients.
Yeah, and like Becca was saying, feeling overwhelmed with not knowing what to ask, there are checklists available for the transition process. So specifically, if you're at a place that doesn't have an established transition program with its own questionnaires and surveys and sort of itineraries of how to do things, but being empowered to take ownership yourself and open your eyes to the questions that need to be asked, and open your medical team's eyes if it's something that they're not as comfortable with or less experienced with.
Thank you all for that. We have a question from the audience. Carrie says, I'm a licensed clinical social worker at a CHD center and an adult CHD patient. I'm currently working on implementing a solid transition program. What do you feel is the best model or way to go about it, since there are so many different approaches?
So I think that's a really, really tough question to answer, because so many pediatric and adult congenital cardiology programs are of different sizes with different resources in different settings, with their ACHD programs built in very different places. So for us, our ACHD team is within a children's hospital. So we can just, tell our patients at transfer time, just go up a couple extra floors and you stay in the same building and this is your home forever. Other places have affiliations between pediatric and adult hospitals, and those require very different types of transition and transfer education to make sure that people can make that jump more successfully. I think probably the easiest thing to do is to use one of the established kind of questionnaires and checklists and introduce it to a medical team and have it be kind of a physician-led process driven by the pediatric cardiologists. That is a tough ask. There's a lot on their plate at these visits already without asking them to do transition education. There are ways for social workers and nurses to do some of the education and actually be reimbursed for it, which is something that we've started doing. So we have a nurse and social worker led transition education program, which we found to be really successful. So they kind of go through the clinic schedule the week ahead, identify people in the transition age group, and then they have kind of a running list of patients and where they're at in the transition education process. And they tag it on to the end of an already established clinic visit to go through it and see where they're at meeting their milestones and readiness for transition. And then they do a formal hour-long adult planning visit when they're ready to transfer or close to ready to transfer, with the transfer process officially being handled by the cardiologist. There's a lot written about this. And so I think it's a matter of kind of looking at the way different centers have done things and figuring out if that's something that is able to be implemented where you're at with the resources that are possible. But it's a really, really tough program. Lots of QI, lots of PDSA cycles, seeing what works, seeing what doesn't work, getting feedback from patients. We have a patient advisory council who helps tell us what is working, what is not working, all sorts of things. So I think it's really tough and definitely not ever going to be a one size fits all answer to that question.
My daughter's center has the adult program in the same clinic as the children's, so it's simple and it's easy. But because we're Washington, D.C., they do a lot of stuff at NIH. And so they say, once you turn 18, we're going to outsource this to NIH, which is great, but it's different, right? And it's going to be different everywhere you go. But I think one of the things that's that they've talked about is they want to have in the transition program, which my daughter hasn't formally entered because they say she's more knowledgeable than the average 17-year-old about her diagnosis. Whether that's true or not, I don't know. But we talked about it a lot forever. But what they do is they've got, 3 or 4 different visits that they schedule throughout the year that are telemedicine to, well, I don't know if you call them telemedicine because it might be with a social worker or someone, where they'll talk about insurance or in just one visit, or pharmacy in just 1 minute, or how to make an appointment. And I think that's wonderful, but there's no way my daughter would do an extra appointment. She has like 30, 35 appointments a year. To add on like 3 or 4 more a year, she's like, there's no way that's going to happen. So, I mean, you've just got to look at the patient and see, are these teenagers going to come in for extra, even if it's telemedicine, are they going to spend an extra hour? Is it better to do it in a group setting? I don't know, but you got to kind of look at your audience and see what's going to work.
We had the same experience with trying to set up additional visits. The no-show rate was astronomical because no one wants an extra visit, versus if you're already somewhere tacking on an extra 15 minutes, 20 minutes when you're there is much more palatable. So you get kind of a captive audience and sort of force the issue when people are there. We do some like teen nights, some parent only nights for transition age people. And I think the kind of group things, pre-COVID, we would do pizza nights, things like that, which were pretty nice. So I think the group things, the social aspect of it makes it a little more palatable, but our attendance still is not as good as when we kind of see them at their standing clinic visits.
The other thing I would encourage you to do is to try to reach out to a social worker at another program, because I think, as a resident physician, I feel like I have I have some understanding, but a much more limited perspective of what your job as a social worker looks like. And so like giving, your approach to your job may not be as impactful as reaching out. Like recently, I can tell you, I was looking at how to build up like support group networks here. And so I looked at kind of what was ongoing in research on clinicaltrials.gov and reached out to social workers that were putting on studies, and was just so thoroughly like encouraged and surprised by like the fact that they all got back to me and were all willing to meet to talk about the ways that they were studying and their experiences with setting it up. And just like the collaboration, I was just really, really impressed by and really touched by. So I would also like not hesitate to think about reaching out to centers that are meeting with success, especially if they're using a social worker model. I was really impressed with the amount of time that folks at other institutions were willing to dedicate to help us out in New Orleans. I thought that was great.
Yeah, so if you are interested in this, you can send your information to Becca, and I'm happy to connect you with a social worker at Texas Children's, because she's been effectively running the program for many years now and does an amazing job. So may have insight, like Dr. Jenkins was saying, about how you can sort of lead the charge to improve transition at your center.
Thank you for that. We are just about out of time. I would love to hear from all of our panelists as a parent and an education director. What advice would you give to patients and families about staying in CHD care, whether they transition to adult care or remain with their pediatric cardiologist?
I go first. One thought that I have had is that when we were having some challenges and needed to change cardiologists when my daughter was 11, if we had chosen to just not make appointments with anyone and just kind of thought she was okay from then on, which she was really healthy at that point, if we had chosen to not do that, I'm not sure she'd be here today. And I mean, maybe that's an earlier age that would happen than the average patient, but she had an emergency pacemaker implant. She's had several other emergencies as well. And staying in care has been life-saving for her. And I think the transfer was great, but the transition is the rocky part, because it's the ongoing, like convincing her she needs to ask questions and empowering her and letting her know that it's okay, and building that relationship and having her feel comfortable. Those are the big things right now.
I would say from an older patient perspective that sometimes adults can be a little bit more stubborn. Well, I guess teenagers probably can too, but we think that we're okay and we're fine and we don't need to take care of ourselves. but staying in care, I did have my own gaps in care, but finally coming back to it has allowed me to live a more active life and a happier life and a full life. So as annoying as it can be, not being different from your friends or interrupting your life, that it really does help you in the long run.
Yeah, and I would just say there's no dumb question. And the nice thing is that occasionally somebody asks a question that you yourself as a doctor haven't thought of, and it makes you realize that that's a blind spot for you. And asking those questions in a way is helping you not just advocate for yourself, but you're advocating for people like you too, and helping your physicians and your team to get better, to make sure that you're giving the care that you need, but then also that other people like you are getting that care too. So never feel bad about asking those questions.
I agree with everything that has been said so far. I would say for parents, helping encourage your children to be independent from early on. So encouraging your pediatric cardiologist to address your child instead of you from an early age. So redirect the questions to the patient. So it's very easy, for a doctor to talk to a 3-year-old's parents. That probably makes more sense. You'll get more information. But really, really early, get your doctor in the habit of talking to your child and get your child comfortable with talking to their doctor. And that really simple fact from a very early age helps make those conversations easier, helps empower them from an early age. One other really specific thing that I would encourage you to do around the transfer process, hopefully lots of transition education has happened, but if you can ask your pediatric cardiologist to identify a specific adult congenital cardiologist, so instead of saying go to ACHD, have them pick out a name. Ideally see if that person can pop into clinic and at least put a face to a name and know who you're going to see when you come forward. Or at that very first adult congenital visit, if it's logistically feasible, have your pediatric doctor pop up and say hi. Just help smooth out that process and make it seem a little bit less jarring. It makes a really, really big difference for patients and for families to see that their pediatric cardiologist, who they've grown to love and trusts this new person to care for them and the expertise they have in adult congenital care. So advocate for that for yourself and for your family.
Well, thank you all. This was an absolutely wonderful discussion. Unfortunately, we are running close on time. We would like to say thank you so much to all of our panelists for sharing your expertise and your lived experiences and for thoughtfully addressing questions from our audience. We appreciate, as always, your partnership in educating patients with CHD and their families. And thank you to you, our audience, for joining us as well. We would like to thank our Heart Connection 2022 sponsors. Your generous support enables us to bring crucial educational programming like this to patients with CHD and their families when and where they need it most. For more information on the Heart Connection virtual webinar series, including upcoming topics, or to submit follow-up questions, please visit us at conqueringchd.org/involvement/Heart Connection. If you'd like to support more programs like this one, please visit our website or scan the QR code directly on your screen to donate. Join us this Friday, August 5th, for our next Heart Connection webinar, a conversation with clinical experts as well as patient and parent panelists about how families can foster independence in patients with CHD, especially when it comes to managing their CHD care. Check out our website for more information. We hope you'll all join us next time. Have a great evening.